in place at Apollo so that people appreciate value of care. It's not about me doing individual practice. So that's my dream. Let's see how it goes.
Correct, sir. Nice, sir. I agree with the same thing with here, sir, because we acquired all Columbia. Now we have almost 12 hospitals in Bangalore itself.
I know. You know, I always wonder if you thought about, if supposing you're doing business and you have a successful business in Mumbai, say a hotel, you will put the next hotel in Rajasthan or in Bangalore, or no one will build 8-10 hospitals at one place. Apollo have so many in Chennai. You all have so many in Bangalore. Right. This concept is, maybe it's the brand, the credibility now among Bangaloreans. You all are well.
Yes, sir.
And you all are expanding tremendously the money.
Yes, sir. Yes, sir. Yes, sir. We might also, take over Medanta and all other. And now AMRI also just will be probably signed.
So, do you practice or are you part of the board or you do?
Sir, I'm part of board, sir. I'm in board since 10 years and I'm also chairman of Manipal Health Enterprise Private Limited, Onco Global. So, we have hospital in Nigeria, Lagos, Malaysia and all, So, I'm a chairman for all the group. I'm also in mode, but I practice hectically, sir. Like I operate Sunday 7-8 cases. From morning 5 a.m. to 3, we operate, and 3 to 9, I run OPD.
So then why don't you, when do you relax? What do you do?
So I'm managing between.
Okay, good. Nice.
Maybe at this point, age is on my side, sir, but maybe I'll cool down.
No, please, you must. If you can contribute to society, you have a talent, you must give back. This is my belief. Yes. I would like to teach, participate, operate till as long as God gives me good health.
Correct, sir. Every month I do about 150 major surgeries, sir. Because wow. But I get 4 OT every day morning.
But that means you have a good team.
Yeah, very good team, sir. I have an excellent team I put up. Huge team.
That is good.
Thank you. Nice. Thank you. Dear trainees, welcome and thank you for being here today. I'm Navneet Singh, your host for this webinar. I know that today's topic will bring a number of questions from you. So you may type your questions in chat box and I want to let you know that we will address as many as we can in the time we have today. So I welcome and request Professor Dr. Soma Shekhar to start this session. Thank you and over to you, sir.
Thank you very much, Navneet Singh ji. Welcome all students. It's my honor, pleasure and privilege, like when you introduce teacher of teacher, on a topic which he has done excellent work, and in India the thyroid malignancy and the work of Professor Dr. Anil Cruz is synonymous. Nobody can introduce him. He himself is an institution in an institution. He has presided over thousands and thousands of trainees when he was in director of TMH Mumbai. But more than that, he brought the first honor to India, being the first ever president of UICC. Is also the president of Indian Society of Thyroid Surgeons. More than that, what I really admire is, in spite of being such a celebrity brand figure, is down to earth. A first year student joined today can walk, speak, interact with him with the same ease as his peer, who would be his co-director over many years and decades. Excellent teacher. His first passion is teaching surgery, head and neck surgeries. So it's like I taught this topic to the students where most of the time 1 in 2 candidate would get a thyroid malignancy in practical, or in a practical somewhere you would hit it, or definitely you have a question in theory. So and he has such a busy schedule, I was even apprehensive to approach him. But just one talk and then he told, my first passion is teaching, I'll do this home and then I'll do next. It's my honor, pleasure and heartfelt thanks to Professor Anil Cruz for having accepted this. And the way it will be run today is he has split the whole talk into about 4 different sections because that's how I wanted it. I went through all the question papers of NBE board over last 10 years. And since I am an examiner both for MCH and DNB surgical oncology, you know that this is how students get caught up. Approach, workup, management, and what are the trends and how did we evolve. Many times to understand a disease in head and neck, you must know why we evolved like this. So since there are 4 components, at the end of each component, as suggested by Professor Anil Cruz, to break monotony, he will give a pause, he will take questions, and then he move to section 2, 3, and 4. So it will be lively, and I request students, you don't know the value of getting him to address you, please utilize it fully. Sir, over to you, sir. Thank you very much. Welcome.
Thanks, Soma, for those very humbling words. Thank you very much. I'm deeply touched by the introduction. Navneet, thank you so much for helping me get through the logistics last evening. It's really a pleasure to be here today, be part of the NBA Surgical Oncology teaching program, and speak on a topic very dear to my heart, and that is thyroid malignancy. Thyroid forms 1% of all cancers. If you Google, you'll see over 4 million sites on thyroid disease. They say that there is a new paper on thyroid every 8 hours. It's important, as Soma said, for your theory, for short case, for long case. You can even get it on the tables for instruments, operatives. It's very difficult for me to cover all aspects of thyroid in this 1 hour, but I'll give you all an overview of flavor so that it's easy for you to be able to understand thyroid. As Soma said, I've divided my talk into 5 subheadings where I will have the following learning objectives. Recognize the exponential increase in the global incidence of thyroid cancer. We'll then understand how to triage thyroid nodules based on the risk of malignancy. Then we will look at the management of differentiated thyroid cancers, which is really huge. If I have time, I'll cover medullary thyroid cancers. Otherwise, I'll jump to recent advances. I have kept the 4 headings that Soma has told me about approach, diagnosis, management in mind across these 5 subheadings. So we'll first look at the exponential increase in the global incidence of thyroid cancer. And youngsters, good morning to you. This could be part of a theory question for you. So focus on this and then we'll take any questions on this. In 2013, there was this publication in the British Medical Journal showing that the incidence of thyroid cancer is increasing. Now, let me get my pointer on here. So here you can see that the incidence of all cancers is increasing from the 70s onwards. But the majority of these increases were only in papillary thyroid cancer. Follicular and poorly differentiated were a static line over 3 decades. While incidence increased, the mortality of these cancers was flat. It hadn't changed. And you can see that smaller size nodules were more diagnosed than very advanced cancers. So an increased incidence, predominantly papillary, smaller size nodules, no mortality change. I'm going to break and tell you a story about Korea. Korea, many of you all may have been there, you all have heard about South Korea. They have a very aggressive healthcare program. So for $400, they were screening for 5 cancers, all below the clavicle, breast, bronchus, bowel, prostate, etc., etc. Someone smart said that add $25 and we can do an ultrasound of the neck. Look what happened to the incidence of thyroid cancer in Korea. It shot up to 68 per 100,000 from 4 to 5 per 100,000, all papillary, and the mortality was flat. 1/4 of surgical patients had tumors less than 0.5 centimeters. Surgery resulted in significant complications. Now, I want you all to remember that when you all did your pathology and autopsies were performed, you must have read there were 2 cancers that were discovered in the human body that had no biological significance. One was thyroid and one was prostate. So if you did autopsy on people over the age of 50, you could see 10-15% of these indolent or laboratory cancers. So maybe screening unnecessarily was causing overdiagnosis. So for your clinical practice, when you'll get your degree and start practice, don't unnecessarily screen a patient for thyroid cancer. And then this big alert came from the WHO, published in the New England Journal of Medicine, that 470,000 women and 90,000 men have been overdiagnosed with cancer in 12 countries. Focused on the last bullet, it has also increased in India. When I was your age and I trained at the Tata Memorial Hospital, we used to see less than 100 thyroid cancers in a year. When I left at the end of 2018, we were over 1,200 thyroid cancers in a year. And the numbers in Tata's may be 10, 12-fold, but it's increased all over the country. We now stand at about 4.5 to 5 per 100,000 in our country. So it's not only overdiagnosis, and this is something you'll have to say in your theory. There are people who say there is a true increase in the incidence of thyroid cancer. The increase in incidence of larger tumors is also seen, and you all will see it as you all train in your various hospitals, that it's not only all less than 1 centimeter. We see palpable nodules, and we see nodules which are more than 2 centimeters. If improved detection was responsible for the rise, then we should have seen all histologies. We should have seen more medullary, more follicular, more poly, but we are only seeing papillary. And the increased incidence is not proportionally distributed for age and gender, which would have been had it been purely due to better detection. So we are diagnosing more cancers. They may be increasing in numbers because of some etiological agent that we have not laid our hands on. It could be the iodization program across the globe. But many of these cancers are indolent. They grow at the rate of 1 to 2 centimeters per year, and we are picking them up much earlier. So we only need to focus on thyroid cancers which are relevant and not operate or treat laboratory cancers. I finished the first objective. If there's any questions in the chat box, I'll be delighted to answer them. Otherwise, I'm moving to the next, which is triaging thyroid nodules based on the risk of malignancy. I think since the first section was pure epidemiology, I'll go to this section and then take questions. So remember that in your exam, you will get thyroid either as a solitary nodule or as multinodular. 50% of cancers present as a solitary nodule. But solitary nodules are very, very common in the general population. 4 to 8% in Western world have nodules on palpation. In our country, 10 to 12% have a little goiter if you examine people. If you catch 100 people on the railway station, you'll find about 10% will have a palpable thyroid. If you did sonography, 30 to 50% of your patients would have thyroid nodule. But malignancy is not so common, so you can't operate all 10% of Indian population for thyroid. Only the ones that are risky you need to operate. But when your youngsters work in referral centers, the incidence of patients referred to centers is 5 to 15% because you all are specialists. In the general population, with the general practitioners, it will be 10%. But the ones that come to you, who are referred to you, 5 to 15% will have malignancy. So we need to triage which ones stay in the community and which ones we diagnose, operate, manage, and treat. Now there are different criteria on whom to evaluate. ATA, which is the American Thyroid Association, has various criteria. The NCCN guidelines have various criteria. They say that investigate all nodules irrespective of size. The ESMO has different criteria. And the American Association of Clinical Endocrinologists have different criteria. But if you just look for a second on the slide, you'll see the 1 centimeter coming out very, very strongly. There is something for 2 centimeters, which I'll tell you, but it's usually 1 centimeter. So you will only evaluate nodules more than 1 centimeter. You will not evaluate. So if you're in your consulting room, someone has had an ultrasound for a carotid screening, and the nodule size is 0.5 centimeters, that is 5 millimeters, you don't have to rush in to evaluate. You will only evaluate less than 1 centimeter if they are high-risk features, which I will tell you, and that is on history or on sonography. But all of us being in cancer, many people will undergo PET, and irrespective of the size, a PET detected incidental loma has a fairly high incidence of cancer, which could be as high as 30% in the published literature. But please remember, only nodules more than a centimeter unless they have high risk features. And here is a photograph of a PET detected incidental loma. Incidental lomas now could be a second short note that y'all could get in your examination. I don't have time to go into incidental lomas in full, but you must keep this in mind. PET associated incidental loma are known as pains, because sometimes it's very difficult to decide whether to treat or not to treat. I've shown you a photograph, and I'm making a very relevant point. When you see this isolated hotspot, focal uptake, that is a matter of concern. If it's a diffuse uptake, it is thyroiditis. So you must see a focal uptake. Now, to treat these patients, it depends why the PET was done. If the patient has metastatic breast cancer, don't waste your time doing a total thyroidectomy on this patient. So that's a broad philosophy of managing these PET-associated incidents. I said that patients could present to you in the exam and in your practice as a solitary nodule or a multinodular goiter. Now, here is a meta-analysis by Yuan Brito looking at the prevalence of thyroid cancer and multinodular goiter versus a single nodule. Focus on the 2 red boxes that I have done. In countries outside the US, the incidence, those of you all who are familiar to read the forest plot, this is the line of unity. On the left is less cancer with an MNG. On the right is more cancer with an MNG. So outside the US, the incidence of cancer is less in a multinodular goiter. And if you look at iodine sufficient to iodine deficient, again it is statistically significant. In locales which are iodine deficient and they have multinodular goiter, the incidence of thyroid cancer is less as compared to those who are iodine sufficient and live in developed countries. So when a patient comes to you with a multinodular goiter, it may not be as dangerous as with a solitary nodule, but some amount of multinodular goiters will have cancer, and you must know to triage these nodules. And that's why ETA give a cutoff size of 2 centimeters if it's multinodular and there are no suspicious features on sonography. Now your examiner is going to ask you a question. Doctor, there are 100 nodules. Which nodule will you FNA? So remember, your answer is, sir, it does not depend on the side. It depends on the sonographic features, which I'll share with you. So only if the sonography is suspicious, that nodule will be targeted. And you may have to target multiple nodules in a multinodular goiter. If the appearance is uniform, then you can target the biggest nodule, which has less colloid, or have a representative sampling across the thyroid to get a more representative FNEC. When working up a thyroid nodule, there are only 3 tests that you will do. TFTs, thyroid function test, a fine needle aspiration cytology, and a sonography. There is no role of serum thyroglobulin preoperatively. CT, MR, and PET should not be usually done. So please remember only 3 simple tests in the nodule, and that's what you have to say. The examiner will ask you, which one will you do first? Always you'll do a thyroid function test first. It's simple, it's a blood draw, and it's easily available. Once you see the thyroid function test, if the TSH is low, you are dealing with a toxic goiter. And that patient will go for an isotope scan. This is the only role for isotope scan today for diagnosis. The other role for an isotope scan is for ectopic thyroid. If you have something in the mediastinum, you're not sure, anterior mediastinum, you have something in the lingual thyroid region. But for normal, the only indication for doing an isotope scan is a suppressed TSH. This is an autonomous nodule. Raised TSH, which is on the upper side of normal, is usually associated with malignancy. If the patient is grossly hypothyroid, it is usually not cancerous. The only goiter that can occur in hypothyroid is people who have thyroiditis and then have a rapidly enlarging thyroid, and it's usually a B-cell lymphoma. So remember that a normal TSH is associated with malignancy, and it's slightly on the upper side of normal, and those patients will have further investigations. The second test you will do is a sonography. Remember that the sonography is operator dependent. So don't send the patient to just anybody for sonography. The person must have experience, and you must use a probe, which is a small part, high frequency probe of 10 to 15 hertz, megahertz. You cannot use what you do for pregnancy, for abdomen. It has to be a small part. And you do ultrasound because it's safe, it's non-invasive, it's cheap, and easily available. It alters the surgical approach in about 20% of cases. You can see the characteristics of the nodule and the rest of the thyroid. Remember these 3 things that I have told you. Cystic nodules, spongiform nodules, and hyperechoic nodules are very rarely malignant. It is hypoechoic, hypo, that is malignant. You use an ultrasound to target an FNAC for small nodules, posterior nodules, repeat nodules. If you are observing a patient, you can see the growth of the nodule with time. And earlier they had objective criteria of greater than 50% increase in volume, 20% in diameter, or an increase or decrease of 2 millimeters that told you that you need to take action. But now this has changed. And the new ATA guidelines, you will only repeat FNAC if there's suspicious sono features on ultrasound, which I'll share with you. And plus the sonography is good to pick up nodes. So that is why you do the ultrasound. If the examiner asks you what is the advantage, the negative is that it is highly operator dependent. Now, both for your exam and for your clinical practice, if your sonologist does not report the sonography in ThyRads, which is the Thyroid Imaging and Reporting Data System, it's a free download. Please go see it. That person is not doing justice. So please see that they report in ThyRads. And youngsters, when you read a report, remember that ThyRads is based on 5 features. Solid nodules are malignant. They should be hypoechoic. They should be microlobulated. Microcalcification, which probably is the highest specificity for malignancy. And they should be taller than wide. Remember, both for breast and thyroid, it is micro. Macro is benign calcification. Now, depending on the number of these features that are present, they triage or increasing risk of malignancy. You have all 5 features, the cancers of malignancy upwards of 85%. So TIRADS is something you'll be asked bedside, and TIRADS is something that can also be a short note in your theory paper. Make a note, free download. Please read it and keep it ready. And the third investigation that you do is thyroid FNAC. It decreases unnecessary surgeries. It's the investigation of choice. It's cost effective. Now remember, both from your clinical point of view, bedside, when your examiner is going, he'll ask you, how will you do an FNAC? You must use a small needle, 22, 23 or 25 gauge. You lose a large needle, you will get more blood. Thyroid is a vascular organ. So whenever you do an FNAC, and this is a practical tip for your youngsters, that if the lesion is vascular, don't suck on the syringe when putting the needle in. Just put the needle with the syringe and just do up and down. Some will come into the hub, take out the syringe and then squirt, put air and then squirt what's in the hub of the needle onto a slide. Another favorite question of examiners is, what is an adequate thyroid smear? And the answer is 6 groups of 10 to 15 cells is adequate for a good cytopathologist to give a report. Now here is a classical picture of a papillary thyroid cancer. And this is an exam question bedside. When you, doctor, what will you see? So remember, you'll see smears. See, this is an adequate smear, 10 to 15 cells, 6 clumps, nicely seen. So you see a cellular smear with atypia. You see nucleomegaly. They are nuclear grooves and overlapping. You can see it in all these. But the classical question they want you and they're waiting for you is that the nucleus will have what is known as an orphan Annie appearance. And here I've shown an orphan Annie appearance. Orphan Annie was a cartoon character. And if you see orphan Annie, the entire iris was pushed to the end of the sclera. So look at this orphan Annie appearance. So the examiner is waiting for this. If you forget powdery chromatin, vomatin, they won't mind. They just want orphan Annie, they will go to the next question. Make a mental note that this is what your examiner is looking for. And just as thyroids, this cytopathology is classified into 6 grades of Bethesda that go from Bethesda 1 to Bethesda 6. And the risk of malignancy keeps increasing. Again, a free download and the suggested treatments on the right side. In the interest of time, I'm not going to waste too much of time explaining the Bethesda. But if it is non-diagnostic, you repeat the FNAC under sono. If it's benign, you can follow up the patient. Only if it's a large goiter, cosmetically a problem, you operate. These are called indeterminate, 3, 4, and part of 5, and malignant should be operated. Now, once you have all this information, we make a decision using a diagnostic triad. Clinical features which place the nodule at a high risk for malignancy are extremes of age, less than 16, more than 45. Any nodule in a pre-pubertal child, nodule, not diffuse goiter, that could be a physiological goiter, nodule, has a 50% chance of malignancy. Nodules are more common in females, 5 females to 1 male. So if you have a male with a nodule, your antenna should go up. This may be a malignancy. If there's a family history or some congenital syndrome such as Carney's syndrome, Cowden's syndrome, familial adenosis polyposis syndrome, these are associated with increase. A prior history of radiation, if, of course, the thyroid nodule has signs of extrathyroidal extension or is associated with lymph nodes. Sonography, I've told you, thyroids 4, 5, and 6, more so thyroids 4B 4C, 5 and 6. And fine needle aspiration cytology, which diagnoses upwards of 90% of papillary thyroids. A very basic MS question, limited role in follicular lesions, and the examiner still asks this because capsular and vascular invasion, which is essential for diagnosis of malignancy, is not demonstrated in cytology, and your cytopathologist will place these lesions in the Bethesda 3 and 4. Now, quickly coming to Bethesda 3 and 4 and part of 5, these are called indeterminate nodules. And youngsters, indeterminate thyroid nodule is a short question, and it's also a question after you present. If most of the reports in your case will be Bethesda 3 or 4, or the examiner will ask you it's Bethesda 4, what will you do? 70 to 80% of these are still benign. So unnecessary surgery places your patient at the risk of complications of thyroidectomy. But if there is no surgery, 10 to 15% will have progression, lymph nodes, and will change and curable into the patient getting radioiodine treatment. So don't operate all patients with Bethesda 4, 5. You will have young girls coming. Some pathologist who's not very well expert will give Bethesda 3 and 4. You all will say it's just fine. You're doing harm to that girl. Remember, like sonography, pathology is also, cytology is also operator dependent, and you must get the slides reviewed. So what do you do? And this is what the examiner will ask you. There is a test called molecular markers. Now, this is the third or fourth short note that can come to you, molecular markers in thyroid. The molecular markers are of two types, those that rule in a cancer, confirm cancer, and those that rule out a cancer. So, a rule out is the sensitivity and negative predictive value are complementary. So, it is highly sensitive and negative. So, they're ruling out a cancer, and the test that is done is a GEC or a gene expression classifier. I'll show you a snapshot of a slide after this. If you are doing a rule in confirming the cancer, it should have a high specificity and a positive predictive value. So youngsters, remember P for specificity, E for predictive value, positive. So just remember that so that you'll never get confused. P, specific, positive. The other is sensitivity and negative predictive value. And the classical test was the gene panel test. And today, there have been 4 tests that this is continuously being researched. One is called the Afirma test. I've kind of borrowed this slide. I've not acknowledged it here from a publication where you can see the company, the method, the strength, the test results, and the sample type required. So the 2 most common are the rule out, which is the Afirma test based on mRNA. It looks at 167 genes, and a thyroid-seq, which uses an NGS platform, and this is a rule-in test. This has gone from version 0 to 3, and slowly they're trying to make the latest version that you can do one test to either rule in or rule out. The other tests are the Thyroid Gen X or the Rosetta test. All these tests are complex, they cost money, they're not available for all histology, and which is the best test is unknown. But just because the science is evolving, you all need to know that to offer it to your patients if they come. In my practice, I would be doing these molecular tests, and I have a fairly busy thyroid practice to 1 to 2% of patients. Say you have a film actress coming with a very small nodule. She tells you that, doc, you have to tell me whether it's malignant or no, and I don't want a scar on my neck. If it's not malignant, I'll lose my job. I'd probably tell her do the molecular test. It's between 1 and 2 lakhs. It is available in our country. You can collect and spend. So as of today, in your short note or your examiner, you can say, sir, the science is evolving. These tests are costly. They're not foolproof. There's no one equivocal tests. They're not easily available. They're complex. They're cumbersome. There is some benefit, but the science is evolving, and I'll only offer it to a small section of my patients. CT, MR, PET are never done in thyroid. CT is done only when you have locally advanced disease which is invading the laryngotracheal framework. Cartilage best seen with CT. MR is done best for esophageal and vessel involvement, and a PET is done when there is de-differentiated thyroid cancers and in medullary thyroid cancers when RAI uptake is absent. And this phenomenon is known as the flip-flop phenomenon, is another short note that you can get. So as your cancer is differentiated, they have affinity for radioiodine. As your cancer gets de-differentiated, they do not, or they lose the power to trap iodine and take more of the 18-FDG. So that's why you will get an entity where the thyroglobulin post-operatively is raising, and you will not have any uptake on the iodine scan. It's called tennis. Thyroglobulin elevated negative iodine scan. In these patients, you have to do a PET. I could have taken a whole 1-hour class on tennis. There are various methods on how you take it, but just in the interest of time, note the word tennis, thyroglobulin elevated, negative iodine scan, another short note for your youngsters. So I finished the first two parts of my talk. I'm just wondering if there are any questions. Soma, if you can see into the chat box or...
Yes, sir. There are a lot of questions. Number one, Hari Prasad asks, sir, examiner actually asked us why a thyroid nodule is taller than wide. Is it due to vascularity? And this question is quite often asked. And what should a student say?
So the answer is it's a sonographic feature. It is when you put the sonography probe and you compress this nodule. A malignant thyroid nodule compresses differently from a benign thyroid. If you remember earlier, we had some test called elastography, which used to look at the recoil. So, Hari Prasad, your answer to the examiner, sir, it's a sonographic feature. When you cut the nodule, it won't be like that, and it's because of the compressibility of the nodule.
Sir, next question is pre-op, the three main tests you told. In addition to this, when thyroid antibody we asked, is it a part of routine in all the patients to map out whether they have it along with the thyroid function test?
So a thyroglobulin is never used for diagnosis. Even if you have thyroiditis, your thyroglobulin will be sky high. So you will only use thyroglobulin in the post-operative follow-up after a total thyroidectomy. But sometimes, even if I've done a hemithyroid for a low-risk malignancy, I do a thyroglobulin just to have a baseline. But I will not base my subsequent decision on a rising thyroglobulin in a hemi. I will base it on sonographic features. But it gives me some sort of a semblance. So remember, that's a catch question, and I'm glad someone asked this. Thyroglobulin is never used for diagnosis of thyroid cancer. It is only used for the follow-up of a differentiated thyroid cancer to pick up disease progression, and it is always done with thyroglobulin antibodies. The antibodies can mask or not give a true reflection of the real levels of thyroglobulin. So thyroglobulin never for diagnosis.
Sir, when is antithyroid antibody done? Is it a routine or case-by-case basis? If so, when would we do pre-op or post-op?
Pre-op, please, it is not required. The thyroglobulin antibody is not for malignancy. The thyroglobulin, the antibodies of thyroid are done when you suspect a thyroiditis. But if you're talking specifically for antithyroglobulin antibodies, it is done along with thyroglobulin always. So generally, when you're looking at a thyroglobulin report, particularly if that report is false negative or false positive, always ask for thyroglobulin antibodies. So in the follow-up of a differentiated thyroid cancer, one of the tests we'll always ask is T3, T4, TSH at all follow-ups, and it should be done for the life of the patient every year. We'll ask for a thyroglobulin, and we'll ask for an antithyroglobulin antibody, and we'll ask for a high resolution ultrasound. This is how you follow up the patient. Slowly, emphasis is shifting from doing regular nuclear scans. Now, again, to talk about these nuclear scans, give a whole talk on thyroglobulin antibodies will not be possible in this hour. But suffice to say, it's a test that is done for cancer in the follow-up, and it goes hand in hand with the serum thyroglobulin levels.
Sir, next question is USG guided FNAC mandatory, like, in exam? Should we always say it has to be image guided FNAC of a thyroid nodule?
Yeah, so this is a very interesting question. And I sometimes pick up a bright candidate from I won't say not so bright, but a candidate who doesn't apply himself. So if you read any guidelines, they will say that do it ultrasound guided. And there's enough proof that tells us that if you do an ultrasound guided nodule, the incidence of getting representative material and the incidence of getting a non-representative slide is much lower. But in our country, patients come with big nodules. If the logistics are not there, you have your sonologist with who you practice 5 kilometers from your house, he or she, or from your clinic, he or she is not going to do the sonography guided. It's a big nodule, you can do it in your office and send the patient off. But ideally, the answer is yes. It decreases the incidence of false negative. It increases the yield of representatives, and re-FNACs is cut down by 15 to 25%. Even if the nodule is large, if there's a cystic component, your needle then can be targeted to the most representative area that has some microcalcification to increase the yield. So your examiner is, yes, sir, if I have the facilities, I will do it sono-guided.
Thank you, sir. And Mannar has asked, sir, as per the talk you gave so far, as a part of standard staging workup for thyroid cancer, CT-MR is not done unless those enlisted criteria you put are there, even if FNAC is a positive for malignancy.
Correct. But I'm quickly going to answer this question. Absolutely what I wrote is correct, but in my recent advances, and I'm just looking at my watch, it's 8:15. I'm going to answer this question because some of you all might run off for ward duty, OT. There is an evolving role of doing a CT scan to increase the sensitivity of mapping out nodal disease in differentiated thyroid cancer. So papillary thyroid cancer has a high incidence of nodal metastasis, which could be up to 50%. If you only do a sonography, you will map out disease, but you will not see the central compartment well. Specificity can be as low as 25%. You will not see nodes in abnormal positions, such as the parapharyngeal space. Upper medial pole tumors can go into the parapharyngeal space. If you read the differential diagnosis of parapharyngeal space tumors, the 8th, 9th, or 10th point will be metastatic papillary thyroid cancer. Sonography cannot see that area. Sonography cannot see mediastinum. So now, if you have a node positive patient in your clinical practice, it's a fairly good idea to do a CT scan along with that to increase the diagnostic accuracy, and you have a good mapping of the disease before you go into the patient. So what I do is I do a sono plus CT for node positive. My assistant, my clinical associate, Dr. Satakshi, puts a big map up on the X-ray view box, mapping it ultrasound and CT. So when I operate, I know exactly where to look for the nodes. It's like when you travel and you use a Google map. So that's
good. Yuvraj is asking, sir, I'm always confused when there is a Bethesda 3 or 4 thyroid nodule we are operating. Everybody in our institute say, please don't use betadine solution for painting. He is really annoyed, sir. How does it affect the survey of iodine scan? I'm not able to understand this concept. Please don't use betadine to paint the skin.
So, Yuvraj, you are absolutely correct. And I think I come from the same school of thought that you came from. And this is something that's perpetuated over the generations. So, even if you give a patient an IV iodine injection to do a CT scan, the iodine clears from the system within a month. And it's in the ATH, an Italian study. Within a month, there is no iodine. In fact, after 2 weeks, the fall is precipitous and it does not act and interfere with iodine. But one of our forefathers said this, so everybody tries to act intelligent and say, don't use it. But Yuvraj, I'm giving you a very practical tip. When you finish your surgery, don't irrigate the wound with a betadine solution. Because sometimes you leave back a little bit of solution, your ready-back drain does not drain it out. And I have seen an occasional case where a blob is seen on the diagnostic scan, which could be because of betadine. So in my book, I'm not fighting if you do with betadine. I might do other skin preps, but if you do it, there is no harm in my understanding, because within a month, all iodine is out of the system if you give it injectable. So skin, of course, doesn't have. But please remember, when you're working up your patient for a diagnostic thyroid scan, withdrawing L-troxine after a total thyroidectomy, no ointments to be used. All are these balms that we use, Iodex, Viodex and all have iodine. And the patient is getting hypothyroid. They are complaining of cramps, some feeling of unwell. Then they keep rubbing Iodex and then you will not get a good uptake. So that time it is not allowed on the skin.
Good, sir. Sir, Sunny Khanna is asking, sir, in any situation, can we avoid FNAC if the nodule is, say, 1 centimeter? Question number 1. And then if a patient is euthyroid, should we really do TSH? He says these questions are asked to me in the DNB practicals. Also, is there any role of PET scan as a part of staging in any selected cases? 3 questions Sunny has asked.
So, Sunny's first is the PET. The PET is only done in the staging of medullary. The PET is not done in the staging of differentiated thyroid cancer. But Sunny, sometimes you'll see a patient with very advanced cancer. You are not sure, your pathologist is not telling whether it's differentiated. It could be poorly differentiated. It could be anaplastic. Remember, even for poly and anaplastic, the treatment is surgery if the patient is operable. But usually it's so advanced, it's fixing the cord. You may open the esophagus when you operate. Or if there's doubtful operability, then the best is to do a PET. So remember, PET is done in thyroid cancer for a poorly differentiated to rule out metastatic disease, anaplastic to rule out metastatic, and medullary. So these really are the indications of a PET scan. To answer your question, can you operate without a fine needle aspiration cytology? It doesn't make sense. Because even if you're operating a goiter and you have decided to do a total thyroidectomy, it's a large goiter. You say it's multinodular. FNAC is freely available. It's a simple test. It doesn't cost much. And for me as a surgeon, as you get older, you'll realize forewarned is forearmed. Supposing I take out the goiter and the report 1 in 100 comes for the nodule as a medullary thyroid cancer where the treatment is total thyroid. How will I feel so bad? I've not done a calcitonin before. The right treatment is total thyroid plus mapping out of all nodes. What will I tell the patient? So I don't see any advantage of not doing an FNAC. If it's a purely cystic nodule, you may not do an FNAC because the chances of malignancy are very, very less. But a mixed nodule, cystic and solid, I would always do an FNAC. I'm not sure what the third question was, Soma, the one in between. Can you
Sir, like if patient is either way clinically euthyroid, should TSH be done? Most of the examiner asked this question. Should
yeah, so you will base your clinical findings only on the pulse rate. It's rare to see a patient with bulging eyes and various other things. Any swelling of the thyroid when you are going to operate the patient, plus it helps in diagnosis, it's better and safer to do a thyroid function test. It's simple, it's cheap, it's easily available. If you don't want to do T3, T4, TSH is most important. And you get something known as subclinical toxicosis. You don't want to take a chance. But theoretically, if you do a T3, T4, TSH in an absolutely euthyroid patient, the probability of picking up something abnormal is very, very rare, very rare. But it's something that we do and it's very routine. These examiners who ask these kind of questions are very old timers who have not kept up with time. That will you do T3, T4, why T3, why not only TSH? The cost difference is so little, you don't draw extra blood. These were questions that they asked in the 60s and 70s. Soma, if people ask these questions, since you are the coordinator, see that they're not called for exams the next day.
Sir, unfortunately, sometimes we do get this examiner. So I always tell the students, sir, clinical euthyroid doesn't mean subclinical euthyroid. We have to pick up subclinical hyper and hypo, so we need to do under.
But the incidence is very, very low. So the question is actually, to me, it's a very moot question. So, but I would always do it. It's safe, easily available, not costly. Subclinical can be picked up, and it can push me towards doing a scan in patients who are toxic.
Good. Sir, Hari has a question. Sir, you told about molecular testing. What is the sample? Is it blood? Is it FNAC? Is it core biopsy?
Hari, here it is. Read the last line here. Afirma, FNA passes collected in nucleic acid preservative. Take a screenshot. But Hari, if you get the gold medal, remember me, huh? For the thyroid-seq or the 7-gene test, is FNA passes collected in nucleic acid and the fresh frozen paraffin is embedded tissue. So basically the two most common are from the tissue. Thyroid generation FNA pass collected in the nucleic acid preservative. And here you do a direct smear, it's a thin press and you must have at least 60 cells. So it's basically something done after your FNA and you should have adequate material. I hope it answers the question.
Sir, we'll take last question, then move to your talk. Sir, is there any role of CT chest in a proved case of papillary CA before we do a definitive surgery?
No, there is no role of a CT chest. Now remember one thing, there are two types of metastasis that you could get in thyroid. You could get metastases that are not apparent on investigations before, which will be picked up subsequently on radioiodine scan. So you think that the patient is negative, but when you give radioiodine, particularly in young children, you will have an uptake in the chest. Those are micropapillary or micrometastases in the lung. Those will not be picked up on routine investigations. But large nodules, which are macronodular, seen in follicular thyroid, those will be picked up on routine investigations. Now, supposing a patient comes to you with a normal chest X-ray, the CT scan has gone down to the upper mediastinum, which is absolutely normal. There is no role for going and doing a CT scan of the chest unless the patient is anaplastic or polydifferentiated or medullary. And in those cases, generally, I prefer a PET scan because these cancers can have metastasis out of the chest as well. It could be distant into bone, it could be into the liver. So I would do a PET scan. So routinely, we are not doing a CT scan for all patients.
sir. I think we'll continue with the talk. And sir, we still have time. We can exceed by 20 minutes. No problem, sir. Please go.
Okay. The thing is, I think I'll only do the differentiated thyroid cancer because it's already 8:30. Yes. I'll just do the differentiated and then we'll finish. Okay. Now, remember that thyroid cancers in clinical, maybe you can invite me once more or call me to Bangalore, Soma.
Absolutely, sir. Absolutely, sir. We'll go for a nice dinner, sure.
A nice dinner and you'll have some great pubs. Yeah, Bangalore's known for its pubs.
Sure, sir. Definitely.
And maybe you can invite the student who's asking the most brilliant questions. So 3 of us will go. Okay.
Definitely. Okay, sir.
Thyroid cancers in clinical practice. So now when you see thyroid cancers, in your mind, make up that 90% of thyroid cancers is this blue pie chart. These are follicular cell derived cancers and they are called differentiated thyroid cancers. There are 4 types: papillary, follicular variant of papillary, follicular, and Hürthle cell. About 5 to 10% of cancers are medullary. Medullary come from the parafollicular C cells and are of 2 types, sporadic and familial. 80% are sporadic, 20% familial, and the familial could be familial MTC or it could be part of an MEN2A 2B syndrome. So youngsters, familial medullary thyroid cancer or just medullary thyroid cancer is a short note for you all in the exams. Please prepare this properly. And the last is poorly differentiated, anaplastic, or a lymphoma, which I told you that occurs after thyroiditis and it is a B cell. Now rule out this lymphoma, take it out of this list. All these other cancers are treated surgically if operable. Even an anaplastic cancer is treated surgically if operable. But anaplastic, God has made 2 types of cancers: papillary, where patients rarely die, to anaplastic, which is the most lethal and patients are usually dead in 6 months. So these anaplastic cancers are also operable, but usually because they die in 6 months, they present to us in an inoperable stage. So remember, in the exam, he'll say anaplastic, supposing you'll have an operable lesion. Some examiner, if you go on the 3rd, 4th day for the exam, they're fed up asking the routine questions. They will ask you, I put a needle in, it's anaplastic, what will you do, doctor? Then you will, if your middle stump will go. You should say, sir, it's operable, I will operate. So that is the answer that you have to give your patient. Now in thyroid and differentiated, the goals of initial therapy are thyroid cancer is a surgical disease. You remove the primary tumor, the disease that has extended through the thyroid capsules and all significant lymph nodes. You try to get an R0 resection. I'm going to make 2 points on this. One, if thyroid extends into the trachea, if thyroid extends into the larynx, if it is only confined to the neck, you will still operate the patient. Extended resections give longevity of life. Half the patients live more than 10 to 15 years, which is much better than a locally advanced squamous cell carcinoma of the oral cavity. So please, you will always operate patients who are extended and you can get an R0 clearance. So that's important. By operating, you minimize the risk of disease recurrence and metastatic spread, and you minimize treatment-related morbidity. So we will operate extended resections as well that have come through the capsules. And remember the second point in thyroid surgery, margins don't have to be 5 millimeter to a centimeter as you do in squamous cell or in other cancers. This is an indolent disease. Even if you have a 1 to 2 millimeter margin and you give the patient radioiodine, you don't leave by cross disease. So even if it's fixing encasing the recurrent laryngeal nerve, if you with knife dissection preserve the integrity of the nerve could be beefy red, and you have not left clumps of disease on the nerve, you are good. So that margin has to be microscopically cleared. So remember two things: extended done, microscopic margins. Now, what is the extent of surgery? And this is something that you're always asked: hemi versus total. Differentiated thyroid cancer has a recurrence rate of 2% and a mortality of 1% in a large majority of patients. But it can also have a recurrence rate of 40% and a mortality of 45%. You remove all cancer, you don't want to cause morbidity. So even in the best hands, morbidity can be as high as 25%. Temporary hypoparathyroidism. So in low risk cancers, you will do less, that is a hemithyroid. In high risk cancers, you will treat aggressively and do a total thyroid. So whenever you get a thyroid cancer in your exam or in your clinical practice, when you'll qualify and go on into practice, differentiate good from bad. Now, literature is replete with a number of large databases. Kay, Mendelssohn, Villamoria, Nixon, Adam, looking at papillary thyroid cancers. Large number of patients, 22,000, 52,000, 889, 61,000. Total thyroid versus hemithyroid. Various endpoints. Look at the difference in outcomes. It's not statistically significant. The two studies that did show a favor of total thyroidectomy, irrespective of size, is the Villamoria paper, which is number 3. It's given in the ATA guidelines, and Ian Hayes from the Mayo Clinic. All these other studies did not show, but look carefully. The incidence of total thyroid in all these people who have not recommended total is higher, 88% here, 59% here, 82% of the entire cohort. So preference of people is to do a total thyroidectomy. And ATA, that's why, because there's no randomized control trial, have said if you have a nodule more than a centimeter, less than 4 centimeters, the choice of treatment, the advantages versus risks have to be weighed together. So all patients who are less than 45, less than a centimeter, purely intrathyroidal, it's differentiated, a favorable histology, it's unifocal, no nodal metastasis, absent distant metastasis, have a hemithyroidectomy. All patients more than 45, greater than 4 centimeters, gross extrathyroidal. Now, this extrathyroidal is not capsule invasion, it's gross. Aggressive variants of papillary, widely invasive follicular, multifocal, nodal metastasis present, distant metastasis present, they will have a total thyroidectomy. For lesions between 1 to 4 centimeters, it is a matter of debate, and the pros and cons have to be discussed with the patient. I, in these patients, tend to do a total because complication rates in my hand are less, as well as I will tell you some literature to support my view of thinking. But youngsters, when you are going to practice, if you feel that you are going to give the patient permanent hypoparathyroidism, or you're going to fix the cord, don't do a total thyroid even between 1 and 4 centimeters. Thyroid cancer patients rarely die. They will live and they'll curse you all their lives. They'll be taking 14 to 16 tablets of calcium. They'll go and see other doctors. They'll say, Jarurat nahi tha to do the total thyroid. Or they'll be hoarse. You'll have to do silastic medialization of the cord. So be very careful. Even up to 4 centimeters, if you have a differentiated tumor, unifocal, no metastasis, and a favorable age, it is important. Now, another short question that can come for you is staging of thyroid cancer. And remember, thyroid is the only cancer that has age incorporated into the staging, and that's a point that you have to make. It's rare to have a stage 3 and 4. Even if you have a nodal disease, it's between stage 1 and 2. Here is a meta-analysis looking at thyroid cancer lobectomy versus total thyroidectomy. 13 studies. They've done a subgroup analysis of lesions between 2 and 4 centimeters, and they found an overall survival benefit with a hazard ratio which is significant. Recurrence-free survival is also better with total thyroidectomy as compared to lobectomy. So while some studies, these are all retrospective in the chart that I showed you, there is a tendency for doctors to do a total thyroidectomy once the lesion comes out of the capsule or is like closer to 2 centimeters, 3 centimeters, 4 centimeters, which is my philosophy as well. And the other thing, if you only do a hemi for these larger tumors, 50 to 60% of patients will have bad pathological features when the final histopathology come. I've put up 3 studies. I can't go through them. The first one I've put it because it's from our very own Amrita Institute, that the incidence of adverse pathological features, even in 1 centimeter low risk, would be high when the final histology comes. And so also these other 2 studies from Korea and the US. This is Orlo Clark's group. So basically, these are the reasons why only if it's less than 1 centimeter purely intrathyroidal, I do a hemithyroid. Otherwise, I push my patients towards total. Now, sometime between 1 and 2 centimeters, it's a very value-based decision. You talk to the patients, the family. I told you, you don't want a young girl pre-marriage, pre-pregnancy getting hypoparathyroid. So if it's even a 2 centimeter purely intrathyroidal, then just do a hemithyroidectomy unless you're very sure that you have secured the nerves and the parathyroid. I put up a list of all these cancers because these are all high-grade cancers. Tall cell variant, diffuse sclerosing variant, insular carcinomas, columnar carcinomas, Hürthle cell neoplasm, widely invasive follicular and a hobnail variety. All these types are total thyroidectomy irrespective of the size. So if you don't see well-differentiated classical papillary, your patient needs to have a total thyroidectomy. There is one type which I have not put here, but I thought I will tell you, and that is called a cribriform morular variant of papillary thyroid cancer. The cribriform morular variant is associated with familial polyposis coli. So whenever you have a familial polyposis coli patient that you all are working up in the GI unit, as youngsters who are doing rounds, put your hand on the thyroid. It usually may not manifest at the same time. Either could come before, but put your hand, and if you pick up a nodule, go to your boss and tell him, sir, I picked up a papillary thyroid. He'll be very, very happy. Or if you get a case in the exam, and the examiner asks you if it's a cribriform morular, what will you do? I'll rule out for familial polyposis coli. I'm quickly going to go to the last 2-3 slides and then we'll wind up on lymph node metastasis. Now remember, central compartment is the first echelon of nodal spread, 40 to 50% of cases. You can have nodal metastasis even when the nodal metastasis is very small. Now remember, lymph node metastasis do not have a detrimental effect on survival in the vast majority of our patients, except if it's over the age of 45, large metastasis. And since the central compartment defined between the 2 carotids houses the parathyroids and the recurrent laryngeal nerve, unnecessarily operating on these patients has high mortality. So whether to do the central compartment dissection, there are 2 schools of thought. One school says don't do it, because you have increased hypocalcemia and recurrent laryngeal nerve morbidity, and there's no proof that it improves long-term patient health. The other group says that it does improve disease survival, disease-specific survival, and then you can monitor patients better. You can use radioiodine. Again, this is something that your youngsters can read. I could have gone through it, but in the interest of time, I'll have to go through it. Many meta-analysis, all retrospective data some of them showing a higher morbidity as expected, but basically all temporary hypocalcemia. The results on the outcomes are very varied, but one or two studies do show that the locoregional risk is less. So literature is divided what to do if you have an N0 neck, whether you should operate the central compartment or not. I've put up a paper from Memorial, Memorial Sloan Kettering, but I want you all to view this paper with a lot of caution. It's 1,129 patients over a 20-year period. 470 had PN1, 384 had benign nodes removed, and the remaining 275 had no nodes removed. So they did not know the staging. Follow-up of 70 months, and you can see the disease-specific survival is 100%. But remember one thing, when you read these kind of papers, these are retrospective. The doctors at this institution are world famous. They have used some judgment of their clinical experience, whose node should come out and whose node should not come out. So while it makes a compelling point that nodes may not manifest with disease if they're micrometastasis, please use your judgment when deciding whether the central compartment should be operated. And today, the central compartment is operated in all patients which are node positive. You don't have to be a rocket scientist. It is very, if you see nodes, you have to operate. Advanced tumors, T3, T4, that means more than 4 centimeters extra thyroidal spread, you'll always operate because the incidence could be as high as 90%. And if you have nodes in the lateral neck, remember the first echelon of spread is into the central compartment. 80% of patients with lateral neck disease have disease in the central compartment. So my philosophy, keeping in mind, and this is the philosophy most people follow, keeping in mind the high morbidity of central compartment, on the side of disease, I'll always do a limited exploration. I won't clear out every fat globule in the central compartment. That's trachea to carotid, innominate artery down up to the point of entry of the recurrent laryngeal. I open along the recurrent laryngeal nerve, keeping the parathyroid blood supply intact, flipping it laterally, and I look for nodes. Just putting your finger and rubbing, you can miss nodes. Open little bit, limited exploration, no nodes, I close up and I go home. Lateral neck is always operated when positive. Node clearance is level 2 to 5. Level 1 is never involved. And youngsters, remember, 2 cancers in head and neck that never have submandibular submental node are larynx and thyroid. They can be involved sometimes if they've been prior treated, the neck has been violated, but usually you never do a level 1 clearance. If you're only sampling the nodes or its limited volume, you will do level 2 to 4. There is absolutely no role for berry pricking because the recurrence rates are high. And this is another terminology that old examiners will ask you, what is berry picking? Berry picking is just picking out obviously positive nodes. If you do that, your recurrence rate is very high. So you will always do a proper level 2 to 4. Level 5 we do when there are gross nodes at level 2 to 4. In a study that I did with one of my postgraduate students, and it was her MCH thesis, we found that if you had level 4 nodes, the incidence 2 and 4, the incidence of level 5 is there. So in all patients who have gross nodes at level 2 and 5, we will always do clearance of the level 5, otherwise just 2 to 4. I think at the end of that, when you get the histology and you get the nodal status, you classify your patients into low risk, intermediate risk and high risk. And I've taken this chart from the ATA guidelines 2015. It's a free download. You all can download it. Please note 2 points that I'm making. It's a continuum. It's not very sacrosanct. But generally, if it's intrathyroid and the lymph node volume is less than 5 micrometastasis less than 0.2, they still become low risk. I told you lymph nodes do not have prognostic implication in the wide variety of thyroid cancers. There's an intermediate risk, that is aggressive histology, minor extrathyroidal extension, vascular invasion, or more than 5 lymph nodes, but again, they're not more than 3 centimeters, and a high risk is gross extrathyroidal, incomplete tumor resection, distant metastasis, or lymph nodes greater than 3 centimeters. I'm ending by saying, if you operate a patient today for low risk, no one gives radioiodine post-operatively. High risk, everybody gives. Intermediate risk, it's plus minus, but the majority of these patients would get radioiodine. At least 2/3 to 80% would get. I'm going to end now because we are closing in on 9, and I've got a patient that's induced and I have to travel 40 minutes across the city to get to the operative tables. But it's really been a pleasure. If there are any quick questions, I'll answer. Otherwise, I'm going to show you my last slide, which you all guys can note my number. I'll be very happy to stay in touch with you all guys. And look how many more slides I had. Soma, you should have given me 3 hours.
Sir, yes, sir, definitely not. Each topic I should have given you one session, sir.
Yeah. So here is my coordinates. Youngsters, feel free to get in touch with me if I can answer any of your questions. Go ahead, Soma.
Superb, sir. Sir, there are so many questions. I just know that it's almost impossible to do that. Maybe I'll just to complete it, I'll ask 2 questions. There are over 20-30 questions in chat box. Gayatri has asked, sir, what are the specific indication in well-differentiated thyroid cancer to sacrifice recurrent laryngeal nerve and accept the tracheostomy?
No. Why? So first thing I want to make a comment. If there are too many questions, either I was too dull and caused more confusion, or I kind of kept them together. So I'm not sure what it is. Soma, don't tell me. I don't want.
Sir, obviously the second one, you kept them together, sir. Right?
Okay. So Gayatri, to answer your question, firstly, unilateral recurrent laryngeal nerve does not need a tracheostomy. Sacrificing a bilateral is horrible. In my entire career, I may have only had the misfortune, but it was absolutely a disease, and trust my surgical skills, judgment, my age, no one could have saved the cord. She was a young, pretty girl, and I did save the integrity of both the nerves. It was very, very bad disease. Patient did have bilateral, but I did what's known as a laser arytenoidectomy later, and the patient is decannulated and she's well. She's seeing me 15-20. She's from Guwahati, the girl. But quickly, I want to tell you that the recurrent laryngeal nerve should never be sacrificed. If you have a functioning nerve before the operation, you will always save the nerve. The only time you will sacrifice the nerve is if you are leaving behind clumps of tissue on the nerve. That means gross disease that you can see. Enough studies that if you leave that R2 disease, recurrence is higher, and then that cord will never be salvaged. So here's what my teaching to you all for the exam and for the clinical practice. I always, whenever I take a clinic, I also give clinical tip because you all youngsters will be operating out in the country. Operate the entire thyroid. Operate the entire neck. If you have removed, supposing you are operating and you find the recurrent laryngeal nerve has got disease, if the opposite side is well secured, you have no other site of disease. Your surgical skills are good and you have been able to do fine knife dissection, and still you cannot save the nerve. Only then I will sacrifice the nerve when I have to leave gross disease on a functioning recurrent laryngeal nerve, and it is the only site of thyroid disease which would be left behind. Otherwise, I will never sacrifice the recurrent laryngeal nerve. And in these difficult cases, it's sometimes helpful to use intraoperative nerve monitoring, though there is no no robust data to show that intraoperative nerve monitoring helps in decreasing complications. It is shown to some extent if we do surgeries, otherwise there's no robust data to show that there are at least 8 meta-analysis on this field.
Absolutely. Sir, Yogesh has asked a question. Sir, in AJCC 8 edition, high risk as per age is 55. Previously it was 45. And then if you look ALIS criteria, again 45. So why this disparity, and finally in exam we should say 45 or 55?
You will have to say 45 to 55. So let me tell you, whenever you look at these guidelines are influenced by people who are on that expert committee to give guidelines. I have been on many guidelines. Now the Memorial Sloan Kettering group of Dr. Jatin Shah and others believe that it is very indolent, and they published one paper showing that up to 55 the prognosis was good. But Yogesh, my thing to you is one to answer in the exam, and the second is in your clinical practice. To answer in the exam, you can say, sir, 45 was the cutoff. There is this paper that I showed that up to 55 is there, and the new staging system of AJCC does say 55 as a cutoff. But in my practice, the examiner will ask you, what will you do for the patient, doctor? So you say that, sir, the age is not the only criteria that I will look. So supposing in your clinical practice you have, it's not that if the patient is 55 or 55 and 1 month the prognosis changes. It's a continuum. So if you have a patient between 45 to 55, has a 1 centimeter intrathyroidal tumor, very well differentiated, no nodes, I can push to the 55 age limit. But if I have a patient between 45 and 55 with a 2 centimeter tumor coming out of the thyroid, there's a doubtful lymph node, I will do a total thyroidectomy in the patient. So don't be sacrosanct and say exactly that I want to use the age cutoff. You should be aware of literature. I want to tell your youngsters that the time has come, and I am seeing, I can show you someday when I give a slide or a motivational talk to you all to do research. Lot of good publications are coming from our country. When I was your age, there were hardly any publications. And please don't accept anybody. Read the literature well, interpret it carefully, and please write rejoinders or do trials to help answer these questions. So I don't know if I've confused you with this lengthy thing. 55 is there in AJCC. It's based on some memorial data plus the people who were on the committee when these guidelines were made.
Sir, Mannar asks, sir, is there anything truly called R0 in thyroid? No matter best thyroidectomy you do, tubercle of Zucker candle, thyrothymic ligament, somewhere when you do iodine scan, there is a residual uptake. So is it a myth that it is R0 in total thyroidectomy?
R0, you are absolutely correct. However, meticulous thyroid you do, anywhere between 10 to 25% of patients will have some amount of iodine uptake. I'm going to answer this I'm going to give you 2 points in this. There are 4 areas where you leave back disease. One is the superior pedicle. So please go all the way up, skeletonize the vessels and then catch the superior pedicle, particularly if you're catching it all together. You put a clamp across the superior pedicle, there'll be a little bit of thyroid tissue and you'll get an uptake. Second, you will leave back disease at the pyramidal lobe. Always look for the pyramidal lobe. Pyramidal lobe is usually seen on the left side. Zucker candle's tubercle is usually seen on the right side. So remember, always look for a pyramidal lobe. Trace it. Sometimes it can go all the way up to the hyoid and remove the pyramidal lobe. The third is at the ligament of Berry. So do meticulous dissection at the ligament of Berry. And the fourth is you have something known as embryonal cell rest, which could be ectopic thyroid lying some distance away from the thyroid tissue, usually in relationship to the lower pole. Despite looking at all these points, you're still to get 10, 15, 20, 25% will be iodine, some top pickup. don't worry. Sometimes there is little thyroid between the tracheal rings near the membrane. Don't be aggressive to do that. If you have to leave back little bit of thyroid tissue at the point of entry of the recurrent laryngeal nerve, try not to do it. Have your surgical skills. There is no shame. The biggest shame is to leave back a fixed cord. So please be very meticulous. If the anatomy forces you to leave back little disease, there's not disease, little normal thyroid tissue, there's no problem, because these patients will get radioiodine and the normal thyroid will get totally burnt, and you can use TG for follow-up after that. So your point is well taken, but when I say R0, it should be R0 to your clinical eye, not on radioisotope scan.
Absolutely fantastic. See, for students, they must know the difference between an anatomical total thyroidectomy and the embryological total thyroidectomy. By embryo, you know that the pyramidal lobe goes through an embryo, so you clear thyrothymic ligament because the inferior parathyroid thymus are different. Then tubercle of Zucker-Cattle. So read about difference between embryological total thyroidectomy and anatomical. Sir, this is the last question. We'll end the session. This is Kusha, a very active student. You know, he puts maximum question. Sir, post-surgery in a well-differentiated thyroid cancer, radioiodine therapy, is it like a fixed dose? A low risk will all go to 30, low risk no, intermediate will go to 30, high will go to 100. Or should you do a diagnostic scan, do dosimetry and do it? What should be the right answer?
So there are actually three schools of thought. It depends why you're giving the radioiodine. There are two things. One is called residual remnant ablation, RRA. Just the previous question said that there will be some uptake in the neck. That's called residual remnant ablation. And the other is to treat high risk and metastatic deposits. Now, radioiodine was given in three forms. One is 30 millicuries, because abroad 30 millicuries can be given as a daycare procedure. People can go home, and even our AERB allow up to 30 millicuries to be given as daycare procedure. You are not a risk to other people. Anything above, particularly in our country where the toilets are open, people are pissing on the roads, you can be a health hazard to other people who will get the radiation. So 30 millicuries was given as a fixed dose for residual remnant ablation. Some people used to give a higher dose, but there are two randomized trials. Again, I won't go into them. 30 versus 100, it's exactly the same. Now, when you treat metastatic disease, people earlier, the Europeans would do the dosimetry and calculate the dose. It's cumbersome. There's no proof that doing this is better. So they give fixed dose. So if it's a high-risk papillary, they'll give about 50. If it's a high-risk papillary with extensive lymph node metastasis, they will give about 100. If you have lung metastasis, we give 80 to 100 depending on the uptake, because giving too much and having a very bright intensity might cause pulmonary fibrosis. And if you have got bone metastasis, we can go 150 to 200. So today the dictum is not to do the dosimetry. You either do the low risk domiciliary treatment, daycare procedure, or you go for fixed dose, depending, triaging patients according to the risk of disease.
Sir, thank you very much. What a session it had been. You know, I full-heartedly, I can convey the heart and mind of all 334 students logged in. Their profound thanks, gratitude to you for sharing. This actually shows you are an ocean of knowledge, and people who speak from their experience, and people just read something. Hats off to you, sir. Thank you very much. Wholehearted, thank you to you from NBE teaching program, myself and all 330 students who logged in. Thank you very much. We are ever indebted and grateful to you for your contribution to us. Thank you very much.
Thank you so much. You've always been kind with me, but these kind words will not mean that I have to buy the beer in Bangalore. The treat is
it's on me, sir. Definitely, it's my honor. Definitely.
Okay, thank you. Thank you. Have a good day, everybody, and a great weekend, all of y'all.
Thank you, sir. Over to Navneet Singh ji.
Thank you very much, Professor Anil D. Cruz, for the presentation, and thank you very much, Dr. Soma Shekhar, for joining us. And thank you, trainees and faculty members.